Good evening, everyone. Welcome to Happy Feet. We have a wonderful session for you tonight. Dr. Hannah Fisher is a clinical health psychologist and an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Duke University School of Medicine. Dr. Fisher is a member of the Duke Pain Prevention and Treatment Research Program at the Duke Cancer Prevention and Control. Sorry, I'm trying to let people in here. And Control Program at the Duke Cancer Institute. Dr. Fisher completed her graduate training in clinical health psychology at the University of Miami and her clinical internship and postdoctoral fellowship at the Duke University School of Medicine. Her research and clinical work centers on the symptom management for survivors of cancer. In particular, she's focused on developing, testing, and delivering behavioral interventions that address sleep disturbance and related symptoms of fatigue, distress, and pain reported by individuals with cancer. She is currently funded by a K08 Career Development Award from the National Cancer Institute that seeks to test feasibility, acceptability, and engagement of mindfulness-based behavioral sleep and symptom management intervention for patients with hematologic cancer during and after inpatient treatment. So it looks like you are studying everything that ails us. So we're very excited to have you here. And Dr. Fisher's presentation is called Falling Asleep, Staying Asleep, and Getting Good Quality Sleep During and After Cancer. So I will unpin myself and send it over to you.
Yes, thank you so much for the introduction. Whenever I do talks like this and have someone read my bio, I always tell myself I'm going to go back and simplify the language because there's all these terms and programs and universities, and it's such a mouthful. I'm sorry about that.
You earned it.
Okay, I'm going to share my screen. Bear with me while I get everything situated. Okay, make this a little bigger for you. And then I want to make sure I can see some of you. So let me adjust my video. All right. I think we're sorted. You can still hear me and you can still see my screen.
Yes.
Yes. Okay, great. So, like Jen mentioned, my name's Hannah, and I'm an assistant professor and clinical health psychologist here at Duke. Just want to start by saying thank you so much for having me here tonight. I'm really excited to be with you all to talk about sleep. So my agenda for tonight is maybe a little bit ambitious. We'll see how we go. If I need to condense or cut, I'll do that towards the end. The first thing I want to do is just give you a quick overview of what sleep problems look like during and after cancer. And I'm going to focus specifically on insomnia, given it really is the most common sleep issue that we see throughout the cancer trajectory. And you now know that I'm a clinical psychologist. So I'm really passionate about behavioral non-medication strategies for managing cancer symptoms. So I will spend the bulk of my time tonight discussing cognitive behavioral therapy for insomnia, or CBTI for short. This is really our gold standard behavioral treatment for insomnia. And some of you may know about CBTI. Some of you may have tried it or at least heard a few things about it, and that's all great. I really am going to try to make my talk unique in its focus on the sleep science that goes behind this approach. I really want you guys to understand why we are encouraging the behavioral techniques that are part of this intervention package. So I'm going to give you a little bit of a look behind the curtain, so to speak. I will also touch on some other behavioral strategies that can be useful for optimizing sleep, and also other cancer symptoms. So you heard in my introduction, I'm sort of interested in helping folks across the board with a symptom cluster that includes sleep, fatigue, pain, and stress. We know those symptoms often come together. So I'm hoping the strategies we'll talk about tonight will be really multi-purpose for you and address some or all of those together. And then finally, I'll wrap up by just giving sort of a quick parting word about sleep as a health behavior. And I think that will fit really nicely into what you are all doing in this program. I will try to leave a little bit of time for questions at the end, but there may be a point at which you get tired of me talking. And so if you have a burning question or if there feels like a natural place for us to pause, feel free to raise your hand or just go ahead and speak out. And Jen, feel free if there's a question in the chat, let me know. I can't really see that also all too well right now. All right, so let's jump in. As I'm sure you are all aware, this is probably not a surprise to you all, but problems with sleep are common during and after cancer. And problems that can pop up really center on sleep quality. So that, of course, is how much sleep you're getting, sleep quality, so how satisfied you are with your sleep, how you perceive your sleep quality to be, and sleep timing. So this is really all about, is your sleep falling in your preferred time window, in a time window that suits your life and your responsibilities. On average, about 60% of individuals with cancer report generalized sleep problems or sleep disturbance. So that's kind of a lot. The range is pretty wide though. So if you look in the literature, the low end of the range can be down closer to 15%, but the high end can be basically everyone, near 100% reporting some, amount of sleep disturbance. On average, what we know is that the prevalence of sleep disturbance is about 2 times what you would see in otherwise healthy individuals. And there was a really nice meta-analysis that came out recently that gives us a closer look at sleep disturbance in cancer. Some of you may know what a meta-analysis is, but just to get us on the same page, a meta-analysis is a type of study that summarizes data from a large sample of previous studies. So it's basically a study of studies. And it can be really helpful to give us a sense for overall, prevalence or incidence rates for various things. So in the case of this meta-analysis that came out in 2022, participants were pooled from about 160 previous studies, and that gave us a total of over 46,000 participants. So that's really a lot. We're really happy when our sample sizes are that big. And what they found was that rates of sleep disturbance were highest for individuals aged 40 to 49 years, for those with more advanced disease, for those that are in the middle of active treatment. And looking at specific cancer types, they saw that the highest prevalence rates for sleep disturbance were seen in gynecologic cancer, lung, and then breast cancer. You might be wondering about clinical sleep disorders. So clinical sleep disorders are things that are diagnosed. So you would go to a PCP or a sleep provider, a sleep neurologist, and be diagnosed with a condition based on meeting certain criteria. And how we do that for sleep disorders is looking at 2 specific manuals. So first, the International Classification of Sleep Disorders. And then second, or also, would be the Diagnostic and Statistical Manual of Mental Disorders. So using criteria in these 2 manuals, some of the more commonly diagnosed sleep disorders in the context of cancer include insomnia, obstructive sleep apnea, advanced or delayed sleep phase syndrome. So that's kind of a mouthful. That's basically falling asleep and waking up very early, or the opposite, falling asleep and waking up very late. And then finally, restless leg syndrome. And as I mentioned, I'm going to really hone in on insomnia because it's really, what is most commonly reported during the cancer experience. We see prevalence rates generally ranging from about 18 to 35%. Now, insomnia really involves report from the individual that they're having trouble falling asleep, staying asleep, and or problems waking up too early. So waking up well before you would like to or before your alarm goes off. And what we also need to hear from the individual is that these sleep disruptions are causing some level of distress and impairment. So folks aren't happy with their sleep, and they're seeing undesirable changes in how they feel emotionally, how they're functioning, their behaviors, and or their social interactions as well. Now, insomnia can be acute, which means that it lasts less than 3 months, or it can be chronic. So if someone is dealing with sleep problems along these lines for 3 or more months, they'd be diagnosed with chronic insomnia disorder. So you might be wondering how insomnia develops. And I will just note that insomnia can exist before a cancer diagnosis. So you may be someone that's had issues with insomnia and sleep disturbance before being diagnosed with cancer. And then perhaps those sleep problems are aggravated by your cancer treatments. Alternatively, a cancer diagnosis and subsequent course of treatment might cause new difficulties with sleep. So maybe you had no issue with sleep previously, but this massive stressor in your life has now set a sleep problem in motion. So I really like to think about how insomnia can pop up and how it can persist by using this conceptual model from Spielman. So Spielman came up with the 3P model of insomnia. And I think it's a really useful framework for understanding the development and persistence of insomnia. And the reason it's called the 3P model is because it includes 3 factors. Those are up kind of in the top right of the figure. These factors are predisposing, precipitating, and perpetuating. So hence the 3 Ps. So I'll walk us through this. So first, predisposing. So predisposing factors are essentially risk factors, things about you that might put you at higher risk for developing a sleep problem. So these are usually long-standing traits or characteristics. So extreme circadian preferences. So maybe you are really a morning lark or really a night owl, but you're kind of on the outside range of what would be sort of, typical for time of bed and wake time. Maybe you're someone that's a little bit prone to anxiety, or you just sort of hum at a higher frequency than others. So having sort of a predisposition to hyperarousal can put you at higher risk. Prior sleep problems. So if you are someone that's dealt with sleep problems before, you're going to be more likely to deal with them again in the future. And then there are some things that are outside of our control. So sex and age. Women do tend to be at higher risk for developing insomnia symptoms. And then as we age, we are all at higher risk for experiencing sleep disturbances as well. Okay, so we've all kind of got a certain amount of these predisposing risk factors. And when they interact with some sort of precipitating event, something that, triggers a change in your routine, that's usually a psychological stressor or a biological stressor, the result can be an acute sleep disturbance. So essentially, you're kind of pushed over that insomnia threshold. Precipitating events could be a medical diagnosis, a cancer diagnosis for sure, some sort of procedure, treatments, or even side effects from treatments, pain, fatigue, nausea, hot flashes, you name it. I'm sure you could come up with others. And like I mentioned, when someone experiences a stressor like that, there's often a natural stress response. Sleep gets a little bit wonky, and that's normal. I imagine most of you could recall a time in your life where this has happened. Your sleep quantity and your sleep quality gets disrupted. Now, some things that can happen during this time to really sort of throw sleep off might be changes to your routine. So maybe your activity level changes, your diet changes, there's changes to your social interactions, your family, your work activities. There may be a sharp increase in stress. Perhaps you fall into a little bit of an inconsistent sleep schedule. And maybe you begin taking more medication, so pain meds or sleep meds, or maybe you're needing to take steroids. So any or all of these things can set you into sort of this acute insomnia phase. But usually, once the stressor has passed, your sleep quality and your sleep quantity will improve, and sleep can go back to its baseline. However, for some folks, you may begin to change your behavior. So you're changing your behavior in response to changes in sleep. You start chasing sleep and doing things just to try to get, more sleep. And the things that folks do on the surface feel well and good, but may actually perpetuate the problem and worsen insomnia. So I'm thinking about excessive time in bed. So you might sleep in to make up for lost sleep, or go to bed really early because you had a bad night, the previous night. Maybe you start napping or avoiding activity. Another perpetuating behavior is falling into an inconsistent sleep schedule. Again, as you're sort of chasing sleep, you're sleeping in one morning, you're going to bed early the next night, and you're not really consistent with your sleep schedule. Becoming dependent on sleep medication is another perpetuating behavior. And like I said, all these behaviors seem reasonable on the surface, but if used over time, again and again, in sort of a chronic fashion, can really serve to worsen the insomnia problem. And we'll talk about why that is later on. I want to mention one more thing, and that is altered sleep cognition. So basically, the way you're thinking about sleep. This is another really big change that can occur when you're moving into sort of the chronic insomnia realm. So many people with insomnia become quite anxious about their sleep and really frustrated by their inability to sleep. And over time, this fixation on sleep, anxiety, and frustration about lack of sleep grows. And it grows and grows and grows, and hyperarousal becomes a really key feature of insomnia. So you start to feel really tired, but really wired. So you're exhausted, but yet still find it hard to sleep. Okay, so what about all of this? What's the big deal? And again, I'm sure I don't need to belabor this point to you all, but poor sleep is not good. So of course it doesn't feel good, but it can lead to decrements in your physical and emotional health. It can lead to diminished physical functioning, increased cognitive impairment, and strikingly, in some studies, we're seeing higher cancer risk associated with poor sleep, and poor outcomes as well. So it's certainly something that we want to address. And before I get into talking about CBTI, I want to just acknowledge that it's not just poor sleep that individuals with cancer experience. And I know I'm probably preaching to the choir here. You're all probably nodding and saying, yeah, of course. It didn't take me long to come up with other cancer symptoms that we know are common. And I'm sure, there are others. This is not an exhaustive list, but fatigue came to mind, dry mouth, distress, drowsiness, diarrhea, other GI distress, pain, nausea. I mean, these are just a few, but again, it's not just sleep, it's these other symptoms, and they're related. So you probably know this also. When you don't sleep well, your overall symptom burden is worse. And when you have a worse symptom burden, that can really interfere with your sleep. So it's quite a problematic cycle. Okay, so what do we do about it? cognitive behavioral therapy for insomnia, or CBTI for short, is really the recommended initial treatment for chronic insomnia disorder. And that is across many and global advising entities. So quite remarkably, in 2016, the American College of Physicians gave a strong recommendation that all adult patients receive CBTI as the first treatment for chronic insomnia disorder. So if a physician is telling you to do a behavioral treatment before medication, I think that's pretty remarkable. So they came out with this guideline first, and then the American Academy of Sleep Medicine followed up and gave a similar recommendation in 2021. And really, like I said, this is behavioral treatment being recommended over medication. And that's based on a very large research base showing that CBTI works really well, and it works for a longer period of time than medication. So it has more durable effects, and of course, less potential side effects as well. So I don't presume that you will leave this talk feeling ready to self-administer CBTI. There are trained behavioral sleep providers that can help you with that. But I do want to give you a little bit of a primer to help sort of improve your familiarity with the techniques that are included in this behavioral intervention. So this is a really multi-component treatment package. So basically, CBTI includes several different behavioral techniques that are delivered in combination. And the top two, sleep restriction and stimulus control, are really, I think, the most important, and probably most likely sort of the drivers of treatment effects. So I'm going to talk about those two strategies in detail tonight. But the others, cognitive therapy, relaxation and mindfulness training, and sleep hygiene, are often incorporated as well, based on patient interest or patient need. So before I present the specifics of sleep restriction and stimulus control, I want to just give you sort of some education about the sleep system. As I mentioned at the start of the talk, I think this will really help you appreciate why sleep restriction and stimulus control are so powerful. If you have been involved in CBTI before, or if you're thinking about it or know a little bit about it, there might be some thoughts along the lines of, why are you having me, do this? Why do I need to keep sleep diaries or change my sleep schedule? And I think learning a little bit of the science behind these strategies will help. So this is your course in Sleep 101. So to start, there are two sleep systems that regulate sleep: sleep drive and arousal. And at any given moment, sleep drive and arousal are on opposite sides of a seesaw. So if sleep drive is stronger, you're more likely to fall asleep. And conversely, if arousal is stronger, you're more likely to stay awake. When you have insomnia or some sort of sleep disturbance, it often feels like arousal is winning, even when you don't want it to. So very broadly, the goal of CBTI is to boost your sleep drive and decrease your arousal. So let's talk about sleep drive first. So sleep drive is basically your appetite for sleep. And it determines the amount and the quality of your sleep. So I often compare sleep drive to a balloon. And that balloon gets bigger and bigger as you go throughout your day, and you are upright, and you are wakeful, and you are engaging your mind and your body. That balloon is getting larger and larger. And by the end of the day, you get to cash in on all that sleep drive that you've built up. And the bigger and more taut that balloon is, the more sleep drive you've got, and the more likely you are to fall asleep, to stay asleep, and to get good quality sleep. Now, the things that fill your balloon, very sort of briefly, are engaging your mind and your body. I know you are all doing this in your Happy Feet program, so that's great. Avoiding long naps. When you're napping, you're essentially letting air out of the balloon. So you're squeezing sleep drive out, and a consistent bed and rise time. Things that let air out of the balloon during the day would be sort of the opposite. So inactivity, or avoiding activity, spending time in bed, taking long naps. Again, napping is letting air out of that balloon. Sleeping in or lying in basically is depriving you the opportunity of starting your day and working on building up that sleep drive. Okay, so sleep restriction is a behavioral skill that helps fill your sleep drive balloon. So when someone has been dealing with insomnia for a long time, they tend to spend too much time in bed. So they're kind of trying to catch a wide net for sleep, and that may feel like the right tactic on the surface, but in just a moment, I'll tell you why it's not. So what you see in this picture here is that someone is crawling into bed around 11 p.m. But they're not actually falling asleep until 1. So you don't see the start of that pink sleep block until closer to 1 a.m. They fall asleep, they sleep for a few hours, and then they wake up and they're up for a bit of time, and then they fall asleep again, and then they're up, and their sleep is very fragmented. Sleep restriction helps you right size your sleep by reducing the time in bed to better match the time you actually spend sleeping. So what you see in this picture now is that that same patient is waiting and not getting in the bed until closer to 1 a.m., given that's when he or she is typically falling asleep. Now, I know you might be thinking, oh my gosh, that's so late. But the reason we advise that is because now that person has had 2 more hours to fill their balloon. So by delaying bedtime, we're giving that person more time to fill up their sleep drive balloon, making it more likely that they will fall asleep, stay asleep, and stay asleep the entire night. So you can see that their sleep has become much more consolidated. So by getting their sleep drive up, they're addressing all of those fragments of sleep, pushing them together and sleeping in a much more solid chunk. So I actually like to use the term sleep consolidation instead of sleep restriction. Some people even use the term time in bed restriction rather than sleep restriction. I think sleep restriction can sound a little bit punishing. So let's go with sleep consolidation, shall we? All right, so this is our pulling back the curtain moment. So we've talked a little bit about the science of why we encourage sleep restriction. The actual steps of what sleep restriction look like, I'll show in a moment. But again, want to remind you that there are behavioral sleep providers that can partner with you on this and help you with this. So very quick and dirty, what this looks like. First, you will collaborate with your sleep provider to find a really consistent wake time. So the time that you rise in the morning, we want to try to set that and keep it as consistent as possible, weekdays and weekends. Then you will set a time in bed prescription, and I'll talk about how we can set that up in just a moment. And then we pick a consistent bedtime. Okay, so a note on sleep diaries. What you see on the screen here are sleep diaries or sleep logs. These are the paper versions. There are many mobile apps now, internet web pages that can do this for you electronically. There's something that I like about paper and pen. I still use these in my clinical practice. If you embark on a CBTI journey, you'll most definitely be asked to fill out sleep diaries. These are essentially having you reflect on the previous night of sleep. So you would jot down the time that you got in the bed, the time that you actually turned off the light and tried to fall asleep, your best guess at how long it took you to fall asleep, how many times you woke up, when you woke up for good the next morning, and the time you actually got out of bed. Because you may have snoozed the alarm, so those times could be different. And this may seem tedious, but is actually super critical to the CBTI process. Your provider will take this data and do some calculations, and it will inform how we implement and use the sleep restriction skill. So what happens is, based on sleep diaries that you complete, your provider would calculate your average total sleep time across the past week, or more ideally, it would be the past 2 weeks. The more data, the better. So let's say in this hypothetical, we get 447 minutes. And what we usually do is we add 30 minutes to that. We add 30 minutes just to sort of account for the normal amount of time it might take someone to fall asleep, or if you wake up to use the restroom in the middle of the night. So we get 477 minutes, or pretty close to 8 hours. So this gives you your starting time in bed prescription, your sleep window. Now, let's say this person decided on a 7 a.m. wake up. So this is based on your preference, the time that you like to wake up in the morning, or that you need to wake up to accomplish everything you need to do in the morning. So this person chose 7 a.m. And then it's pretty simple. You basically just work backwards. So from 7, 8 hours back gives you an 11 p.m. bedtime. So this is the sleep prescription: going to bed at or after 11 p.m., but no earlier, and waking up at 7 a.m., no matter how the night went. So even if you have a tough night and you're awake more than you would like to be, we still want to go ahead and get up at 7 and start working on building that sleep drive balloon for the next night. And what I just walked through is sort of just the math of it all. Usually there's some negotiation that happens between you and your provider. We really want to strike a balance between what we know is going to be sort of the most successful time in bed prescription, but also what feels feasible. We don't want to set anyone up for failure here. And now, again, you sort of understand why we might be recommending an 11 p.m. bedtime. It may feel late, but what we're doing here is amping up that sleep drive, filling up your balloon so you can fall asleep quickly, stay asleep, and get that good quality sleep. I won't go through this in detail. It's probably a lot of text and numbers here on the screen for you, but just so you know, after you set your initial time in bed prescription, you try it out for maybe a week or two at home, sort of treating it like an experiment. And then you'll come back, and using the next 2 weeks of sleep diary data, your sleep provider will calculate your sleep efficiency. So your sleep efficiency is basically how efficient you're sleeping. It's a calculation that uses total sleep time divided by total time in bed, multiplied by 100, and it gives you a percent. It's essentially, a metric of if you're in bed, are you sleeping? Which we, ideally want these numbers to be high. And there's 3 rules of thumb that the provider will use. If your sleep efficiency is still kind of low, they might consolidate your sleep even further. If it's too high, conversely, so if your sleep efficiency is like 100%, which would mean as soon as your head hits the pillow, you're falling asleep and you're not waking up one single minute until 7 a.m. when it's time for you to pop up like toast, that might actually mean that we've consolidated your sleep too much, especially if you're still reporting feeling sleepy during the day. So in that case, we would actually widen it out. Really what we like to see as sort of a sweet spot is a number between 80 and 90%. That's usually what we aim for. Okay, so arousal next. So if you recall, that's the other sleep process on the other side of the seesaw. So arousal refers to your body and your brain's level of alertness. So this can be influenced by your circadian rhythm. We all sort of have our own internal biological clock, um, and external factors. So things like caffeine, um, how you've been feeling that day, your level of excitement, your level of anxiety, physical or mental stimulation as well. But importantly, arousal can be learned over time. So if you think of it this way, every time you go to your friend's house, you get some sort of delicious treat. Eventually, your body is going to come to expect a delicious treat when you are over at your friend's house. So you may actually start to get hungry. Maybe your tummy starts grumbling. You start salivating. And this can happen with sleep too, but in a much less lovely way. So what can happen is over time, if you're spending a lot of your night tossing and turning, worrying and getting frustrated by being awake in the middle of the bed, your body and your brain start to anticipate those feelings by being in the bed, or sometimes even by entering the bedroom. And I've actually heard people also say, when I see it getting dark, I start getting anxious because I just know I'm going to be, setting myself up for another night of tossing and turning. Um, Over time, what happens is the bed and the bedroom are no longer cues for sleepiness and relaxation. It's actually the opposite. They become sort of a source of anxiety and irritation. And this is what we call conditioned arousal. And it constitutes the sort of primary rationale for stimulus control. One way to sort of catch, maybe if you're experiencing a little bit of conditioned arousal, is if you are sort of on the couch with your partner or by yourself, and you're watching something and you start feeling really sleepy, and you're thinking, oh gosh, okay, it's time for bed. You move to the bedroom, and then all of a sudden you're wide awake. Or another example, sleeping better somewhere else. So if you're in a hotel room or at family or a friend's house, sleeping better might be, evidence of some conditioned arousal. Not always, but that's something that I typically ask when I sit down with a patient for the first time. Okay, so pulling back the curtain here, the steps to stimulus control are pretty simple, and I suspect some of you may have heard these before already. So really the overarching objective is to keep the bed just for sleep. And if you cannot sleep, either at the beginning of the night or in the middle of the night, you're going to want to get out of the bed, or at least get out of sleep mode. So if getting out of the bed entirely is too difficult, maybe not possible given pain or other physical limitations, just sitting up in the bed and getting out of that sleep mode is good enough. So you're going to want to stay in dim-ish light, but make sure it's bright enough to be safe. The recommendation is to engage in some sort of soothing activity. So something that, is engaging enough, but also not too stimulating that it's going to sort of get your mind super hyper focused on something else. Now, what's key is as you're engaging in this soothing behavior, you're going to want to check in with yourself, check in with your mind, check in with your body, and pay attention to what you're feeling. As soon as you notice that sleepiness sensation coming back, you can return to the bed and see if you might fall asleep. And I'll reiterate that this is something you can do at the beginning of the night. So as you're first trying to fall asleep, and also in the middle of the night, if you find yourself wide awake, unable to fall asleep. Just a few things to keep in mind here. I think I've made note of some of these already, but consider nighttime fall risk. So certainly important that if you're using assistive devices or have some sort of physical limitations, that we're safe first and foremost. So make sure your lighting is adequate. If you need to just stay in the bed, you can use an alternative called counter control, which is just sitting up in the bed. So kind of pulling yourself up from that horizontal position, acknowledging, I'm no longer in sleep mode. Maybe pull out a book or listen to a podcast, whatever it is that you'd like to do as you wait for that sleepiness sensation to come back. Be mindful of daytime dozing. So we'll want to try to find alternative replacement activities for that. And then if the bed is somewhere that you typically go to during the day to rest, maybe that's simply to rest, or maybe that's because you're not feeling well or you're in pain, you might want to consider other locations. So thinking back to the rationale for this strategy, right? If we are spending a lot of time in the bed awake, looking at our computer, looking at our phone, talking on the phone, eating, doing bills, I mean, you name it, we're forming that association in our brain between the bed and being awake, which is really sort of the opposite of what we want. So still take that rest if you need to, but maybe do it on the sofa, do it on your porch if the weather's nice, or in a recliner. Okay. So I'm not going to go into all of the science behind CBTI, but just trust me when I say it reduces insomnia and can also have a really nice benefit to other symptoms too. So we see improvements to depressive symptoms, anxiety, pain as well, and fatigue. And that's just to name a few. So coming back to this diagram, I want to focus again on sort of this cluster of sleep, fatigue, distress, and pain. These are really common symptoms that seem to sort of come in a pack, and certainly can sort of relate to sleep in this bidirectional manner. I actually like to think of insomnia as sort of a 24-hour disorder. So, nighttime sleep impacting how you feel during the day, and then how you feel during the day impacting your nighttime sleep. So I want to actually cover just a few other behavioral strategies that you can add to your toolkit to address those daytime symptoms, fatigue, distress, and pain, which link directly back to sleep. So it's all tied together. And I suspect that you may have already learned some of these in your program that you're in right now. But if not, I think they'll fit in really nicely with what you're doing. Okay, so first, progressive muscle relaxation, or PMR for short. I can't see all of you, but if you have heard of this or tried it, do you want to raise your hand? Give me a thumbs up. Okay, I'm seeing a few. That's awesome. So hopefully this will be a nice refresher for those folks, and also something new for others. This is a really nice evidence-based strategy for noticing feelings of tension, and then conversely feelings of relaxation across your body. And it's really helpful because it can improve our ability to really recognize tension, which is important because a lot of times we carry tension throughout our body across the course of the day without even noticing. And then finally, when we crawl into the bed at night, we say, oof, or I'm in pain. And that's probably because you were holding tension the whole day. So this is a nice skill to sort of cue you in to when there's tension accumulating in your body and helping you to release it before it causes pain. And then it's also just really relaxing. So often people feel great after it, and it can really sort of induce this feeling of relaxation across our body. So the image here on the right shows you sort of the typical muscle groups that PMR focuses on. There's lots of different variations of this skill out there where There may be more or less muscle groups, but generally this is sort of the path starting at your toes, moving all the way up through the top of your head. And I actually want to practice this all with you tonight. So I'm going to play a 6-minute recording in just a minute, and we're all going to practice it together. Before I do that, though, I want to just go through each of the muscle groups and practice how we tense and then how we relax the different muscle groups across our body. So I hope you'll engage with me on this. If anything is feeling uncomfortable or feeling painful, just skip that movement. So starting at your feet, I'd like you all, if possible, to keep your feet flat on the ground. And the way that we want to tense our feet is by lifting up our toes. So your heels will stay planted to the ground, but your toes will arc upwards, such that your toes are pointed to the ceiling. And you should start to feel some tension in sort of that upper part of your ankle. And we're just tensing to sort of a comfortable point of tension. Again, we don't want to feel pain. And then you can release. Exhale and let that tension go. Let your feet plant back firmly onto the ground. Okay, your thighs are next. And so for your thighs, the best way I can describe this is to sort of let the tops of your thighs get hard. And the way that you can sort of begin to emulate this is almost like you're standing up. So you're sort of making the motion to stand up out of your chair, and you should feel the top of your thighs get kind of hard and tense. Continue to breathe, and then let's exhale and just let that tension go. And let your thighs become soft again. Perfect. Okay, so your buttocks next. You're just going to kind of curl your butt cheeks together, pinching them in, holding there briefly. Continue to breathe. Exhale and just let that go, letting them come back to their normal position. Okay, good. Lower abdomen, lower belly next. Here, we're going to just gently pull back our belly, almost like there's a rope on our belly button, pulling it back towards our spine. You should feel that lower part of your belly get tense. Continue to breathe. Exhale and just let that go. Okay, great. Your hands next, or your wrists. Similar to your feet, you can hold your hands out like this. And I want you to just arc your fingertips up to the ceiling. So your wrists, kind of in the top part here, should begin to feel some tension as you're pulling your fingertips back, just to sort of a comfortable edge. And then release. Can let that go. Good. Shoulders. Shrug your shoulders up, pulling them up to your ears. And release. For your neck, first we're going to bring your right ear down to your right shoulder. And I'll advise you just to be careful with this one. We don't want anyone tweaking their neck. Just gently pulling until you feel some stretch and some tension there. And then let's come back to center and do the other side. Left ear down to left shoulder. Good. Come back center. And then let's bring our chin down to our chest. Again, being gentle, just until a point of stretch in the back. And then release, bringing your head back to center. Now, the last motion involves your face, and it can feel a little silly, but just bear with me. So the first thing we're going to do is raise our eyebrows up, like we're surprised, holding them up. Good, and release. And then I want you to make a tight smile, closing your lips and pulling the corners of your mouth back, kind of like you're making an awkward smile. You've just seen someone that you don't want to see. Okay, good. You can let that go. Okay, so that's just sort of a preview. I'm going to play a recording. Again, it's about 6 minutes long. It'll guide you through each of those different motions that we practiced. it'll sort of encourage you to hold that tension for a moment, to study it, become aware of what it feels like in your body, and then to release it and become aware of sort of the opposing relaxation sensation. Okay, so let me make sure my sound is shared, and I'm going to make sure the volume is up. And Jen, you just let me know if this feels too quiet, okay?
Let your eyes drift shut and settle down as best you can. For the next few moments, begin to adopt an attitude that nothing is of much importance other than concentrating on this exercise and just relaxing. Begin by directing your attention to your feet. Slowly begin to bend both of your feet at the ankles, bending the feet upward so that the toes arc toward the knees. Build the tension slowly so that you can study it as it builds. Build it slowly under your control up to a point equally in both feet where they neither shake nor hurt. Now, think the word relax and slowly let that tension go. Now, focus your attention on the muscles of the thigh. Tense these muscles without lifting your legs so that your feet do not leave the floor. Build the tension and study it. Now, think the word relax, slowly letting the tension go. Study the relaxation flowing into your legs under your control. Let the relaxation flow deeper and deeper as your legs continue to relax. Now, focus your attention on your buttocks. Begin to tense these muscles by pinching them together and folding them upward and inward. Rolling your legs outward as you build the tension under your control. Feel yourself being lifted by the increasing tension under your control. Build the tension and hold it. Now, think the word relax and let the tension go. Let the chair support your weight completely. Now focus your attention on your stomach. Begin to tense these muscles by slowly pulling the belly button inward toward the backbone. Continue to breathe more and more with the upper part of your chest, building the tension under your control. Continue breathing with the upper half of the chest, and notice that you can breathe regardless of where the tension is in your body. Hold that tension. Now, think the word relax, and let your stomach sag, relaxing more and more under your own control. Now, direct your attention to your hands. Begin to build the tension in both hands equally by arching the fingertips backward, bending both hands at the wrist, back toward the elbow. Build the tension under your control in the back of the hand and in the forearms. Hold that tension. Study it. Now, think the word relax and slowly let that tension go. Now, concentrate on the muscles in the back of your neck and your shoulders. Begin by raising the shoulders upward, letting your arms roll outward. Begin to tilt your head slowly backward, building the tension in the back and right between the shoulders. Don't force this exercise. Allow your mouth to open and breathe. Hold that tension. And when you're ready, think the word relax and let that tension go. Feel the relaxation of the back of your neck spreading out over your back, relaxing deeper and deeper. Now, bend your head forward, moving your chin towards your chest. Build the tension in the back of the neck and hold it. Study that tension. Now, think the word relax and let that tension go. allowing your head to return to a comfortable, relaxed position. Now, tense your neck by bending your head to the right side, moving your right ear towards your right shoulder. Again, build the tension, but don't force it. Hold the tension like that. Study it. Now say the word relax to yourself and let that tension go. Allow your head to return to a comfortable, relaxed position. Now, bend your neck to the other side, moving your left ear towards your left shoulder. Again, build the tension gently. Hold that tension. Study it. Now, say the word relax to yourself and let the tension go. Allow your head to come rest in its most relaxed position. Now, focus your attention on your forehead. With your eyes still closed, begin to raise your eyebrows, wrinkling your forehead. You're building the tension in that part of your body under your control. Slowly build it up and hold it there. Study that tension. Now, think the word relax and let the relaxation flow. Continue relaxing for a moment or two and enjoy the pleasant feeling in your body, which you've allowed to occur under your own control. Enjoy the deep calm you're providing yourself. In a moment, you'll open your eyes and you'll stretch your muscles. Notice how freely your breath is moving in your lungs. Go ahead and open your eyes, but let your body stay relaxed while your mind is active. Enjoy the benefits of the relaxation that you've provided yourself. You can get your body ready for your daily task at any time. But as you move through your day...
Okay, I'm going to pause us there. I'm going to pull up the chat. And just to get a little bit of engagement and interaction, I'd love for you guys, if you could just type in a word or two to describe how that was for you, anything you noticed, anything sort of interesting that you became aware of, how you're feeling now, anything that comes to mind. Let's just hear a little bit about how it was for folks. Release, peaceful. I love it. It was soothing. Sleepy. Very calm, relaxed, calm. We need like a word cloud to show us what words are popping up. Clearing. I like that. Feel relaxed and unstressed. So this is really great, guys. And that was just 6 minutes. So normally in our protocols that we do with folks, we do closer to like a 12-minute practice. So it's the same motions, but just really kind of long and juicy and drawn out. So I find the 12-minute to be this times 10. But you can see how just a 6-minute practice can really pack a punch. So if you're feeling like you don't have much time, maybe 6 minutes, is something that you could capture in your day and engage in something like this. So when can you use this? So certainly if you are feeling tense, you're noticing discomfort or tension in your body or pain throughout your day, that's probably a good cue to practice this, to sort of work to release that tension. Also, we've been talking about sleep. A lot of people like using this as they wind down for bed. So just like children need a bedtime routine, adults do also. So having kind of a wind down or a buffer zone between your waking activities and your sleep is really nice. So 30 to 45 minutes to just sort of release, the day. And inserting something like PMR during that time can be really nice, just to sort of prep you for sleep mode. Okay. The second strategy I want to talk about is called the activity rest cycle. So this is an approach to activity that involves engaging in a timed amount of activity and then a timed amount of rest. And why we recommend this skill is that it prevents the overactivity cycle. So that's what you see here on the right side of the screen. And I imagine this might be familiar to some. So the overactivity cycle is essentially doing too much activity all at once. And that might be because you finally feel good. You've been feeling crummy, during and after treatment for a while, and then you have a good day and you say, great, I need to get everything done on my to-do list, right? And you go, and it feels good in the moment, but you pay for it later. You have severe symptoms, your pain is through the roof, you're fatigued, and all of that means that maybe you need to rest. And sometimes that rest can last a long time. And God forbid you hurt yourself and you're sort of laid up on the couch for a number of days thereafter, not doing much of anything. I also like this skill because it can increase activity. So maybe that's physical activity, exercise, or just activity and things that you enjoy. And like we've talked about, being upright, moving, engaging your mind and body, engaging in hobbies links directly back to sleep by increasing sleep drive and encouraging better sleep quality during the night. So how it works, it's pretty simple. Identify an activity that you tend to overdo, set a time limit for that activity, and then set a time limit for rest, and go back and forth, essentially, alternating between activity, rest, activity, rest. One thing that I will say, when you're setting your time limit for activity, you should think about it as, how much of this activity do I know I can do for sure without any pain or any fatigue, any symptoms really. So you want to let the clock be the guide, not your symptoms or your body, because usually what happens is if you wait until you start to feel pain or you start to feel fatigue, you've probably already overdone it at that point. So we want to actually stop just shy of that threshold. So pick a time that feels super comfortable for you. Your time for rest should be relatively brief, 5-10 minutes at most. I find that if the rest period gets to be too long, people may begin a whole new activity, and then you're sort of multitasking and defeating the whole purpose of it all. So a brief pause, a brief rest, get a drink of water, get a snack, sit down for a moment, catch your breath, whatever you need to do to sort of take that breather. And then you're back to the activity. So going back and forth, essentially. I'd love to hear from you all again, if I pull up the chat, activities where you feel like this could be useful. So activities that you tend to overdo, or maybe there are activities that you want to get back into, but don't quite have the stamina yet. What's coming to mind for folks? What are some activities that they feel like you could use this activity rest cycle skill? Gardening, crafting, yard work. These are great. Sitting at a computer, that's an interesting one. And absolutely true. You can overdo sedentary activity as well. So you can sort of flip this skill to actually break up sedentary activities. So watching TV, computer, looking at your phone, it works in that way also. I heard Jen mention snacking, right? So sort of quick, movement bites, little moments of movement. That would be a nice way to break up long periods of, being at a computer or sedentary activity. Meal prepping, these are all great. So sort of a nice mixture of household chores, stuff that's kind of like, I hate to do, but I need to do. But then also, things that maybe you enjoy that you just can't quite do as much of, at this moment, and need to break up. Okay, so the very last thing I want to talk about is pleasant activity planning, and then we'll wrap up. So pleasant activity planning is a very simple skill. It's exactly what it sounds like. It's planning fun activities. So this is a simple skill, but really powerful. We know that it can help improve mood. It can help improve coping. It can be a nice distraction from symptoms like pain, fatigue, stress. And again, similar to activity rest cycle, it can increase our activity, which can build sleep drive. And so how we do this is brainstorm activities that you enjoy, write them down on a list, and then pick one out. And actually sort of set aside the time to do it, almost like you're scheduling a doctor's appointment. You're going to schedule this pleasant activity. I find that if you write it down and commit to it in that way, you're going to be less likely to push it to the bottom of your to-do list. When you're making your pleasant activity list, the longer the better. So it's nice to have a really long cheat sheet you can go to. Mix and match. So have a nice variety of things, small, simple pleasures like having a nice bite of chocolate or watching the sunrise, all the way up to bigger things like planning a trip. You want to have a good mix. And then when can you use this skill? Well, really anytime. So this is a very portable skill. I often recommend engaging in a pleasant activity every day. It can be something small. It does not need to be something big or something that costs an arm and a leg. Calling a family member, treating yourself to a nice meal, but finding something meaningful and pleasant every day can be a really wonderful addition to your daily routine. So again, in the chat, if you would humor me and just pop in some pleasant and meaningful activities that you might be able to commit to in the upcoming week. What's coming to mind? Massage, nice. I'd love a massage this week. Walking. That's great. You might find that you can use the activity rest cycle to pace your pleasant activity. So I'm seeing a lot of walking, right? So that is certainly a pleasant activity. Maybe it's something that you need to break up and sort of build in those kind of quick moments to catch your breath. Walking. I love all the walking. That's awesome. Going out with friends, going to church, taking a walk. Great. Okay. So my parting words to you all is that we've been talking a lot about sleep disturbance, sleep disorders, essentially sort of an illness focus. But there's been a lot of push recently in the medical field to start defining health, not by the presence of illness, but rather the presence of positive attributes, like health and wellness. And this shift has made its way into the sleep field. And actually, there's been sort of a definition put on to the term sleep health. It's characterized by subjective satisfaction, so your own perception of how satisfied you are with your sleep, appropriate timing, adequate duration, high efficiency. So are we sleeping when we're in the bed? And are we feeling alert? So sustained alertness during wakeful hours. So I encourage you all to start thinking about sleep as just one of your key healthy lifestyle behaviors. And I was curious, when I Google healthy lifestyle and pull up images, I get a lot that look like this. So a lot of physical activity, a lot of diet, but I'm not seeing a ton of pictures of sleep. And that's a shame, but we're seeing some change when we're beginning to see that sleep is showing up in our conceptualization of what health is. And the American Heart Association made a really interesting change recently. So they had sort of their essential seven pillars of health and wellness. And recently they made a change to include sleep. So now it's essential 8. And you guys are actually on the cutting edge of this. So in your program, right, you're talking about pillars of wellness, and sleep is one of them. And I love that. That is so, so good. So well done to you all for being involved in this. And I'll leave you with a quote from 2 sleep researchers, Gredner and Fernandez. This comes from a 2021 issue of the magazine Science. And they note that sleep is a non-negotiable biological state required for the maintenance of human life. Our need for sleep parallels that for air, food, and water. So I think that kind of sums it up. I have some resources here. I'm happy to share my slides if that's of interest to anyone. Some books that can be useful, different websites and mobile apps that I like, and also some treatment referrals if you're someone that would like to see if maybe you can get some help for insomnia or other sleep problems. And that's all I got. I know I'm a little bit over, but hopefully we can have a bit of time to take some questions now.